Good afternoon, Madam Chair and members of the committee. Thank you for the invitation to be here today. To briefly situate my perspective, I am a trauma therapist who has been working with veterans, CAF members, and RCMP members for the past 17 years. I'm also clinic director at Mind Spa Mental Health Center, an affiliate within the PCVRS network. Since joining the network, we have supported nearly 100 veterans across Quebec, Ontario, and parts of Atlantic Canada, both virtually and in person, services being offered in French and in English. Our virtual model has also expanded access to veterans in rural and remote communities who might otherwise face barriers to care. Over the course of my career, I have seen the rehabilitation program evolve from a system coordinated directly by case managers to the current PCVRS model. Today, I'd like to offer a balanced perspective, what's working well, and where there are clear opportunities to improve. To start with strengths, I have seen improved access to care, particularly for veterans in remote regions. Many now connect with appropriate providers more quickly without having to navigate the system on their own. This has reduced barriers and allowed veterans to engage in treatment sooner. For example, I recently worked with a VAC case manager to coordinate care for a veteran who was not yet on the rehab program. Scheduling that initial appointment took several weeks. In contrast, under the PCVRS model, once a rehabilitation specialist is involved, appointments can often be arranged within days. That difference in timeliness is significant, particularly for veterans in acute need of support. We also saw this early in one of our first PCVRS participants, a veteran who was incarcerated and who would typically face significant barriers accessing care. Through the program, he was able to engage in treatment while serving his sentence, and we saw clear measurable improvements in his mood and overall functioning. When the model is working well, I have seen strong multidisciplinary collaborations with coordinated care across providers. I also see standardized reporting practices and the use of outcome measures to track progress and inform care. That said, one of the most significant challenges I experienced early on, and one that continues to be echoed throughout the committee and testimonies we heard today, is a lack of clarity and education around the nuances of the program. This lack of clarity, if left unresolved, has real clinical consequences. In response, I have made it a priority to maintain open lines of communication between our team and the PCVRS team, including Peter Adams and Karen and Dr. Bourgeois. We have received support when clarification is needed. Closely tied to this is a fear among veterans of being cut off from the program or losing access to services. While the structured, time-limited nature of rehabilitation is intentional and important, it's not always clearly communicated. As a result, some veterans experience the program as rigid and high stakes. I want to emphasize that the system can work well when flexibility and clinical judgment are applied. For example, I worked with a veteran medically released for PTSD who had already completed a comprehensive assessment. A reassessment was not clinically indicated as it could risk destabilizing her. Through collaboration with her VAC case manager, we readjusted the plan and moved directly towards a determination of diminished earning capacity. This is an example of the system working as intended, but it required advocacy and a level of clarity that isn't always made available to veterans or providers. At its core, I'm observing a model with strong foundations and clear impact with opportunities to enhance how it's experienced on the ground. The program is already working for many veterans. The opportunity now is to build that success and ensure that it works consistently for all. In closing, PCVRS represents an important evolution in how rehabilitation services are delivered. It has improved access and introduced greater structure and coordination. For it to reach its full potential, it must be clear, consistent, and well understood. When those elements are in place, the program has the capacity to be truly transformative for the veterans it serves. Thank you for your time.
Based on your clinical experience, including your work at Department of National Defence, what has your experience been working with veterans seeking mental health care?
I think one of the things I've noticed is the transition piece is one of the things that come up most often. Identity, adjusting to life as a civilian, navigating the healthcare system as a civilian versus those who were working as active service members. That's one of the main things I would see is navigating the nuances of being a civilian.
Okay, that I can appreciate that for sure. So did you notice similar needs amongst veterans that you'd been working with?
Yeah, I think that's one of the biggest things we explore, grief around identity and who am I now, and having to navigate, again, getting simple family doctors, for instance, or even the healthcare system. But those are things that I often see both with those I served with before and who I work with now.
Right. Thank you. As you mentioned, a virtual program, I believe, as well. Can you explain, are there differences between an in-person session or program and the virtual program that you would have offered?
I think we're in a stage now where virtual healthcare or virtual mental health care can be as effective as in-person mental health care. I think at this point, it's almost being able to realize that having access to the support is the most important piece versus no support at all. There are some interventions, perhaps like EMDR, that are preferred to be done in person, but can still be offered virtually as well. And so there's a lot of similarities with the virtual versus in-person care.
What was that acronym, EMDR? Can you explain what that means?
Yeah, so EMDR, it's eye movement desensitization reprocessing. And so it does use a couple different tools like light bars, but the idea is to engage in bilateral stimulations. That can be done virtually, just showing the client how to do that on their own.
Okay, that's really cool. Sounds cool. I'm more of a meditation kind of gal. So in the 30 seconds we have left, you talked a lot about some of the challenges. What suggestion are there one or two suggestions you could make that would improve the service?
I think having clear expectations outlined to veterans who are entering the program in terms of what to expect as you enter, or if you decide to enter into the rehab program, managing those expectations, I think will be very important, as well as on the case manager side, because they often have the initial contact with the veterans before they are entered into the program. And so I think informing the case managers as well as the veterans very early on what the program is and what the expectations are of the program.
So based on what I heard from Mr. Thorne, he said that veterans are a unique population. So I would like to ask you, and I will start with Ms. Massunken, is this true? Are veterans a unique population?
Absolutely. I would say that they are a unique population. They have a culture of their own. Their experiences are different than that of civilians. I would definitely agree that they are a unique population for many reasons.
Is it appropriate to group the specificities of veterans in one single group? I'll ask Mrs. Massunken first.
Is it appropriate to group them into one single group? I think we always want to be able to look at each individual's presenting concerns and needs and treat them accordingly. Despite there being some similarities and common threads among the groups, there are always going to be differences amongst them, and it's important to take those into consideration.
I'll get back to you, Madam Massunken. From the point of view of mental health from your organization, what kind of factors influence positive results within veterans?
What type of
factors positively influence the veterans?
What factors? I would say having community would be a positive factor that influences their wellness from a mental health standpoint, whether that's a social network or community network, something similar to what they were used to while they served. That's a huge and significant part to their wellness. Having that social support, being able to lean on that social support in different environments has been a significant aspect to their wellness.
Je vais essayer une autre question en français. J'espère que
That question in French, I hope you don't mind. Are there any obstacles that stop veterans from getting to mental health services such as the kind that you propose in your own clinic?
I feel like we've done our best to work through some of the barriers, whether it's a language barrier or a geographical barrier or a regional barrier. We've done our best to be able to identify that. I think one of the biggest barriers that continue to exist for some would be the stigma around mental health and accessing mental health care. What would this say about me? Whether this is a sign of weakness or what this might bring up for me. I think that's one of the biggest things that we've seen, the stigma around mental health care and accessing that care. The access piece, the flexibility around peace. And so when it comes to assessments, is that required all the time, or are there flexibilities around what that might look like for individuals? In addition to flexibility, I would say accessibility and flexibility for individuals entering the program.